Thank you very much for joining us. This is one of the webinars that we're doing under the Gulf Interventional Society. And actually, this is the first structural heart disease webinar. Luckily that we able to collect the most senior TAVI and structural implanter in the Gulf area today. So basically today we'll go over TAVI cases in COVID-19 era. The question that we're going to raise is that TAVI is emergency or not? And if it's emergency, shall we do it or shall we defer it later on? And if we're going to do a cases, which cases should be done at this time? Then what is the special parameter that we should do during the COVID era? As all people know that we are restricted now to elective cases. So from today presentation, hopefully at the end of it, you will have a clear guidance to which patient should be done during this period. And inside the cath lab, are we still the same before COVID, or we should change to decrease the personnel to deal with our cases in a different way? Personally, I think it's the TAVI implantation will be similar in every center after COVID-19 because all people will follow a specific regulation. So that's basically what we're going to cover today. I want to thank you all for attending with us this webinar. And without any further ado, I'll introduce our speaker and panelist. So our speaker today is Dr. Thomas Modine. He's an interventional cardiologist in Center Heart University in Lille city in France. Well-known TAVI implanter and proctor with the Medtronic company. Also, our panelist, Dr. Mohammed Al-Ataibi, is a senior interventional cardiologist in Prince Sultan Cardiac Center in Saudi Arabia. Dr. Fahad Basleb, well-known interventional cardiology and CEO of Rashid Hospital in Dubai, United Arab Emirates, and Dr. Khalid Al-Marri from Chest Hospital in Kuwait, senior interventional cardiology. I would like to, on your behalf, welcome them all, and I wish you have the best 1 hour going over our presentation. So without any further ado, Thomas, it's your time now.
Thank you very much for the introduction, dear Fawaz. It's my real pleasure and honor to be with you here to share not our experience, but to give some guidelines on what was happening in Europe in the last discuss a bit together and give some orientations to our colleagues and to get profit. So yes, you have it? Do you have it?
Yes, we can see the screen and we can see you very well.
Okay. You cannot see me.
No, we can see you and we can see the slides. Go ahead, please.
You see the slides now?
Yes.
Okay, good. So I wanted to share with you what's happening in Europe and what we can discuss all together, and how, based on this pandemic, we have been able to redefine the lines that defines the TAVI activity, and even beyond the TAVI activity, everything related to structural disease. So this is, for example, just to give you an idea about a comparison of the countries that are in Europe, and for which you can see easily that one of the explanations that made Italy, France, and even Holland and some other countries subject to a big threat in terms of needs for ITU beds, and we lost a lot of patients where the lack of means basically because of the lack of intensive care beds. I wanted to show you also one of the on this slide, a recommendation that is almost the same in all European countries, which we have been asked as to deal with, which are, we had to reorientate our activity, and you'll understand why this slide is important. we had to orientate our activity towards only emergency patients. And we had to give different colors, or risk 1, risk 2, risk 3, depending on the country, and to be able to fit with the policy of the Ministry of Health, who orientated all the means and all the human power available in the health system in France and in some other countries, of course, toward the COVID. And in many countries, we have been forgetting the burden of cardiac disease and especially valve disease. And this is why we are here today. So in the beginning, we have been forced to select only patients in the red column, and then orange, and then yellow. And of course, we had to forget everything about elective care patients. And I think this slide is very important. It will lead us through some of the discussions, I'm sure. I'll leave it to you later on, because where do you put the patient? And if you consider it an emergency, is it emergency today or in 1 week? Given the landscape of the disease, which is long-term the disease, so where do we fit, where do we sit, where do we position our aortic stenosis patients? So this is a quick slide just to show you. I'm sorry to remind many of us this, and it's not only destined to us as cardiologists, but it's also important to share with our governmental people and health system people, is that aortic stenosis kills. Aortic stenosis, the natural history of aortic stenosis is a killer. And we all know that it could lead to heart failure patient, to prolonged hospitalization. But also we forget this. It leads also to some neurological defects and problems. And we know all of us that you have some myocardial infarction which are related to aortic stenosis. And this is a very important matter, because in many countries we have been sacrificing the TAVI programs because it was not emergent and an emergency affair. And this was a big mistake, because many patients have been paying the price. So once we have done this, we have been then asked to provide a better view to optimize the TAVI flow. And of course, I'm going to focus on the transfemoral. So we have been asked, because of the COVID, to adapt our approach for TAVI. And this is what I call an adapted minimalistic approach, AMA. And we wanted to focus on some points. We'll discuss them all. But the practice that we use for TAVI that we can offer to our patients today. So we wanted to be sure that if a patient, but beyond the fact that he's red or yellow or orange, we wanted to be sure that if we hospitalize a patient for a TAVI, we wanted to be sure to have a short procedure. So that means we wanted to optimize the hybrid room or the cath lab occupation. We wanted to be sure that everything is set in place to have a better recovery and early discharge. And this also will help having a better availability of the means, lowering the costs, because you all know that because of the COVID, we had all extra costs for the society. And so we needed to participate in making things better. And by doing all this together, we have been able to do not only one TAVI a day, sometimes 2 and 3, and approach our daily practice. So how did we maximize the procedural efficiency? First, we were looking at what is the pathway to lead to early discharge. And I mean, you know this, what we wanted to be sure that the way we have been screening, the way we have been looking at the patient and adopting the indication is really good. So we have been spending much more time on pre-screening. We have been assessing much better coronary and iliofemoral angiography, because for us, it was a moment to take zero risk and make the patient take a zero risk. We wanted to enter the hospital, do the case, leave the hospital with almost a parallel pathway to the COVID pathway. So we minimize the contact, the patient comes quickly, leaves quickly, he's safe. There is only one question that we have been forced to raise, and politically it was not always as easy as we can imagine, but it's in hard times, men and women should take the right decisions. The heart team. So, you know, I mean, if there is a trust within the team and between the cardiologists and the surgeons, we believe in each other and we respect the guidelines and the way through the indications. I'm not sure that in the time of COVID, bringing all these people together, delaying the indication of the patient is mandatory. So this is a big question mark. And always if you put the interest of the patient first and the society next, I think in this moment, heart team is a big question mark. Then we wanted to move to practically the way we have been doing things. In many, you know, the majority of TAVI cases are today done by the general anesthesia, but the reality is almost half of the TAVI practice all over the world. Of course, it's not about Gulf area of Europe, because I'm sure that this webinar is followed by colleagues from all over the world. Is we wanted to get away from general anesthesia, because if we do this, we don't need necessarily to have a full-time anesthetist available. And by doing this, the anesthetist can do cardiac surgery, can do ITU work. And this is what we call optimizing the human power which is available. I mean, this is, I will go quickly through this. This is one publication in 2018 that was showing clearly that if we compare general anesthesia to non-general anesthesia, the patient is not losing any chance by having local anesthesia versus general anesthesia, and there is no difference in terms of mortality or safety or efficacy of the procedure. So general or local are equal, but are they really that equal? If we go into the details, the minimalistic approach, starting by a local anesthesia, has more favorable outcomes than we think, because as simple as it is, you will not need to intubate the patient. So no trauma because of this. You don't need to insert the esophageal probe. So no trauma because of this. And the patient can recover quicker. And you don't need to put additional lines. And this is very important. No additional lines, no risk of infection. Patient can start walking immediately after the procedure. And all this together can lead to early discharge. So this is how we wanted to start with. And then we looked where the troubles come from. What we wanted to avoid it, to be sure that TAVI is meeting of the doctors, patients, hospitals. So we wanted to look at how to prevent the complications. You know, like me, that vascular complications are still very important, and in real world, sometimes it's even higher than the pacemaker rate implantation. So we wanted to avoid this. And we even those who were not believing in it, adopted now widely on regular basis the use of echo Doppler puncture. And you can, the beauty of it is that you can really avoid puncturing the artery on a calcification, and you can be sure that you are really on the anterior wall. And this is, to be honest with you, in my own practice, not only in the other centers, it showed to be very, very, very effective, and reduced to 0.2% the number of patients with whom we had vascular complications. The other major problem with TAVI, and you know this, is conduction disturbances. So we wanted to now adopt the best practice also in order to eliminate conduction disturbances. And this is what we do today, and this is what we have been putting in place, and we have been asking all the implanters to respect and do. We look at the CT scan, we calculate the depth of the membranous septum, and we, of course, we implant using what we call now a cusp overlap, which gives you a better idea about the position of the device according to the annulus. We also, by positioning the catheter of the Evolute R correctly, achieve what we call a commercial alignment, in order in case, during the case, but also after the procedure, you need to go back and need the coronary access to achieve a commercial alignment. And to avoid putting a temporary pacemaker wire in all patients, which I can tell you can spare 80% of the pacemaker temporary guide wires. And this is economically very efficient. We were stimulating patients over the wire. And this is very important. We can talk about it later, how we do it effectively. So this is the way we looked at things. And even if the patient, using this method, we have been implanting patients even with the right bundle branch block, avoiding any need for pacemaker in them. And if in case you need to implant a pacemaker, you just have to watch and follow up the patient. And if any left bundle branch occurs, you can put a temporary pacemaker wire and observe the patient for 24 hours. If nothing happens, now our policy is to discharge the patient. And this is, I can tell you in our experience, showed to be very effective. And now we have a pacemaker rate with the Evolut R, which is below 10%, far below 10%, which is very, very, very good number. And I'm sure we can improve a bit more in the future. So putting this in mind, minimizing the risk, we have been able to achieve what we call early discharge. And this slide is very important. It summarizes a bit what we have been doing. So instead of taking all the responsibility ourselves, just when the patient come in, we have been sharing the responsibility. So we have been spending more time on case selection. We have been stratifying the risk, but we have been forced to in order to be sure that we have been respecting the indications of the Ministry of Health, and we engage our responsibility to achieve early discharge. And so the patient was accepting to come to the hospital. Many patients were very, very frightened about the idea coming to the hospital where there is a lot of intubated patients because of the COVID. And also it needed some education with the patient and the family. And I can tell you, they like this very much. And of course, we optimized our practice in terms of peri-procedure practice. And all this together led to early discharge of the patient. So this is my last slide. It summarizes what we knew already, but we have been able to confirm thanks to the COVID, or pushed by the COVID, that for TAVI kills. Aortic stenosis is a killer. TAVI is a fantastic therapy that now has been shown contraindication, also intermediate risk and low risk patients. It's not our topic today to refresh the memory of our colleagues about the efficacy of TAVI. You know the publication in the New England Journal of Medicine with the low risk Evolut R implantation. So I think we are not all convinced, but I think it's our duty to optimize the environment of TAVI and to close the discussion with the surgeons, with anyone else. And you know that part of my job is a cardiac surgeon also, is by ticking all the boxes that secure the procedure from A to Z, we have been able to offer to the patient the best of our indications. Thank you very much.
Thank you very much, Thomas. It's a very great presentation and slide, and it delivered a lot of excellent information. From this, we'll go to our panels. But before that, I'll just for the audience, I'd like to encourage you to send your question to us, and definitely at the end of our webinar, we'll go over them with our speaker and panelist. Maybe we'll start with Dr. Mohammed Al-Ataibi. Dr. Modine raised an important issue that severe AS can kill patient. It's an emergency situation. So what do you think about this and the nature of the disease? Is this emergency really, or is it an elective procedure?
Thank you, Fawaz. Sorry. Thank you, Thomas. It was a nice lecture as usual. You see, I think this is a very important topic. And the first element you asked about is the disease. And we know, as Thomas said, that a severe AS is a killer. And that's why the new description in this COVID era is to say that severe AS is a time-critical condition. This is very important. So we know from the surgical literature, we know also from the TAVI literature, that if you waited, for example, in surgical literature, if you waited for a month, there is a 4% mortality for those with severe AS waiting for surgery. And it's the same percentage waiting for TAVI. But if you extend it, because the TAVI patients are sicker than surgical patients and older, there is a more chance of dying for TAVI patients waiting. So this is a very serious issue. So I want to emphasize that this is a critical, severe AS is a time critical condition, is a killer also. We know we wanted to try everything possible to avoid the patient exposed to COVID, but I think if it is severe symptomatic aortic stenosis, and by severe, I mean mean grade more than 40, and by, or the area below 1, and by symptomatic, I mean symptoms NEHA class 3 or 4, that's heart failure or syncope or low ejection fraction. This is, I think, you need to treat these conditions. These type of patients with severe symptomatic AS, I don't see that they can be delayed, particularly if they are in hospital. So if they are in hospital, I think they should be treated. So the first class of patient is severe symptomatic. Second one is severe minimally symptomatic. And the third one is asymptomatic. So I think our main discussion is to stress to the audience that severe symptomatic AS is a time critical condition and is a killer, shouldn't be delayed.
Excellent, Dr. Mohammed Athabi, and a great point. So, Dr. Khalid Al-Marri, so if that's a situation, whom should be done during this period and whom should be deferred? And is there any way to classify this patient? And if we select to do a case, what we should do before we do the procedures and a specific parameter that we have to follow these days?
Sure, nice presentation, Thomas. And I agree with Mohammed about this is, AS is a killing disease. The problem in this pandemic, we have another killing disease. So we have two killing diseases. And the problem with this one is, as Thomas said, we have to preserve the resources. And this pandemic, there are things that are important to preserve and use wisely, like ventilators, ICU bed, as Dr. Mudin said, the number of ICU beds per 100,000 people is, in some countries, is limited. So those are things that you have to manage wisely. The other thing that we faced in Kuwait is the blood reserve, blood bank, did not have enough blood at one point because donors, they didn't go to donate blood. And now you're trying to manage your resources wisely, and regarding the infection as well. The other thing is patients are safe in their houses, and you don't want to get them to do TAVI and they get infection to avoid a killing disease to get another dangerous disease. Those are the restrictions. Those are the fears that we are concerned about in the pandemic. That's why we have to be wise and choose our patients wisely. And because of the limited ventilators, ICU, blood, risk of infection, that's why even patients with AS who are supposed to go for surgery, maybe it's better to choose TAVI because you are preserving those parameters. I think patients that will go for TAVI, usually they are symptomatic, but not every symptomatic patient we have to do TAVI at the moment. So as Mohammed said, we have to risk stratify them. Patients who are class 3 to 4, we can't wait on them. Patients who they have low LV function, we cannot wait on them. Patients with syncope, we cannot wait on them. Patients who are inpatient, so you cannot discharge them and tell them, well, we'll see if you're going to be stable after that, and then we'll evaluate. I think those patients should be done.
Excellent, Khalid. Dr. Basleb, so now we decide to do a TAVI. So what's thing different nowadays? As we mentioned, and Thomas mentioned that some of the center they still do general anesthesia. Actually, some of the center in Saudi Arabia they still do cut down with the surgeon and OR team in the room. So a lot of people involved in the procedure. What is the best strategy, and is COVID-19 going to push us to change our technique and practice inside the cath lab for TAVI patients?
Okay, first of all, thank you for the invitation. And Thomas, is a nice talk as usual. I mean, in every crisis, there are opportunities and lessons to be learned. And I think that's what we should emphasize on. The most important thing, I would like to echo everybody, that the mortality from severe aortic stenosis is higher from even than COVID-19. So we should focus on this, and COVID is there, and we have to live around that. We cannot stop all the care because of COVID-19. Okay, there are limited resources, but I think there are some opportunities to be learned here. So after the selection of patients, the patient that needs to be done, okay, I think we have, there are things that we have learned. I'm going to divide it to pre-procedure, procedure, and post-procedure. So pre-procedure, we have to use like the telemedicine, virtual clinic that you can interview the patients. The anesthesia pre-workup can be done through the virtual clinic. Even the heart team meeting, also we care about the staff, so we don't need to get all the staff into one room like what you used to do before. We can do a virtual meeting, Zoom, Microsoft Team meetings, so then can be discussed to optimize the best strategy for each patient, because you want to minimize the complications. And heart team meeting is the way to do it nicely using a virtual thing. Regarding the procedure itself, I mean, we used to admit the patients the day before to do like blood work and everything, but I think we should emphasize on the same day admission. You bring the patients on the same day. You don't need to use a critical care beds because these are very valuable. Ventilators are very valuable. I think this is the opportunity for people who used to do under GA. Now they have to change their practice to minimalist approach. And I think most of the centers, they are doing minimalist TAVI, but it's an opportunity for the other centers to move that. Even for the people who are doing minimalist approach, they have to do it in a very adapted manner, as Thomas mentioned. So minimal people in the room, that's very important. Only necessary people should be ready in the room. And I think once, before taking the patient to the room, the staff inside should be ready with their PPEs, okay? And of course, one of the pre-tests you have to do, plus your echo, plus your CT, you have to do a nasal swab, because always we care about the staff. So staff safety is very important, and there are only limited people do TAVI in the region. So we have to make sure that it's a routine COVID screening is done for those patients. Then, as I said, team should be ready with their PPE. Then we bring the patient on and we start the procedure under local anesthesia, no additional lines, no TEE, please. And we do it and try to minimize complication as much as you can. And also to use the device properly and appropriately. We would like to have, because most of complications is because of femoral complications. So we have to be ready with all the necessary devices, and also to use a device with low profile sheet. And then once the procedure is done, patients shouldn't go to the CCU, should go to a monitored bed. That's very important. And that's what we are doing even before COVID. So a monitored bed, and then early discharge, next day discharge, that's the way to do it. I think that's very important. Minimize the duration of admission, because these population, don't forget, they are fragile population, they are frail, their immunity is very low. So we don't want to treat aortic stenosis and give them COVID-19. So minimize their stay in the hospital. Thank you.
Excellent, Dr. Fahad. I'll just go back to Dr. Modine. There is one of the question here from people attending us. Is he said, how do you expect to ensure maximum procedure safety if we are going to fragment the team? The heart team, including anesthesia and CT radiologist or cardiologist with us, and the surgeon. So you already touched base on the virtual clinic and virtual heart team, but I will ask you in depth on that. And also he mentioned that selection between the valves. And is there any specific valve that should be considered in the COVID-19? I think he means that for less risk for a pacemaker or anything else. So Thomas?
Yeah, so for the first question, I wanted to be clear. There is no competition in my practice and in my mind between cardiac surgeons and cardiologists. So this is, take it for granted. And I think if a TAVI case could be done with the cardiologist within the confine of a heart team because people trust each other, while the cardiac surgeon is doing something else and he's busy and he cannot be present. So first, there is no reason to delay the TAVI because of this. And the cardiac surgeon can use their resources, for example, the anesthetist, and do another case of surgery. So this is very important. This is the way I see my practice today. This is the way I do it. And this is how I see the future. If any one of us would put himself in cardiologist against the surgeon or surgeon against the cardiologist, it will lead us to this kind of questions. I don't believe in this, and I'm not gonna extend on it, I would say. This is very important. Now to the valve selection, this is very important. First, I know that there's a lot of talks and publications based on that tells that with the Evolut R, I mean in CoreValve in the fast, Evolut still a bit, we have more pacemaker than the balloon expandable devices. This is true and not true. And this is a partial vision of the problem. This is true if you still implant today the Evolut R like the way we have been implanting the CoreValve 15 years ago when we started back in 2006. But the practice has changed now. And this is what I said in one of my slides. Now, before selecting the patient, we don't only look at the diameter of the arteries and if there is any calcification in order to choose the root, femoral or not femoral. And we don't only look at the aortic valve itself and the height of the coronaries to choose the size of the valve. We look at something else. We look at the membranous septum height, which can help us. I mean, the conduction abnormality, starting by the left bundle branch, is mechanical. And you know, because this even happens when you do a balloon valvuloplasty. You don't need to insert a valve to have and this is temporary. And you know also that in all the publications, in 50% of the patients, there is no need for, and because I really think whatever the valve you are using, you have to be much more careful about the place where you position your valve. You have to spend a lot of time on it. I'm sure that also the pacemaker could be a killer in the future, but it's too easy to say because you don't want to make the effort and implant the valve correctly based on what I said, the membranous septum height, and making a projection using cusp overlap, implant your valve calmly, and then you can achieve exactly the same number. This is in my practice, whatever the valve you are using. So there are two ways of seeing things. You choose the easy way or you choose the best way for your patient. I still believe, for example, that a gradient, high gradient in valves is a bad thing for the patient. And this, you will see it in the future, can lead to halt, which means thrombosis of the valves, earlier one, but mainly to jeopardize, I would say, the durability of the valve. So having a valve which is supraannular is very important, especially in small anatomies, for example. If you want to do a valve and valve, and so on and so on. And there are some patients where you can implant both valves. You can use any one of them, the one you like. But I disagree with any one of us that would say, I want to choose a balloon expandable device in every patient because there's no pacemaker rate. This is not true. We have to adapt and use the new techniques of implanting, very humbly.
Yep. Thomas, tell us about your experience of doing TAVI in the COVID-19 era. I know you did 2 to 3 cases.
Yes.
Is that different between your routine practice of TAVI?
So for us, this is a good question because there's a lot of patients, but also colleagues of us that make a kind of, they are lost in between. So let's make a separation between a COVID plus intubated patient, I would say severe one, and a COVID plus, which has been diagnosed plus because we did the blood test. So in the COVID plus, only because of the blood tests, there is nothing different. We just have to be more careful that there's no direct contact, and especially doing local anesthesia is also helping a lot because we don't have to intubate. There is no exchange of secretion between the patient and the anesthetist or the nurse. So to be honest with you, we prepare the patient much better. We make more, we put more distances between the patient and anyone who is present in the cath lab or the hybrid room. Otherwise, the procedure is the same, and I'm happy to say that even the outcomes are the same. So we have to do it. This is not true. The problem is completely different with patients who are intubated, with severe COVID patients, because unfortunately it showed that the patient will not get any benefit out of it. But luckily, these are very, very, very few. We had to do it only once.
Good. So, Dr. Mohammed Ataibi, I think, did you do any cases of TAVI recently?
Yeah, we did, but he was COVID negative, but he was a heart failure with a clear afterload mismatch and low ejection fraction. And luckily, I think what we did differently is two things. Number one, I did it alone with a senior nurse. Maybe he's watching us, Aziz Al-Anizi. So you take the senior guy, it was only me and Aziz. So you minimize the personnel. This is very important. One important thing is that there is no trainee. You shouldn't allow trainee in the structural heart to go in these cases during this time of pandemic. Number two, we didn't take him to CC. We took him to the monitored bed, as Dr. Fahad said. And next day was discharged. So I think you minimize the procedure, personnel, in a degree that you don't affect the perfection of the procedure. You shouldn't jeopardize the procedure itself. And I want to say one comment in this issue, maybe Dr. Fahad mentioned it, that those who are doing TAVI under GA, it's the time to shift. Yes, but I think it's the time to shift the patients to people who are doing conscious sedation. Because in my view, there is nothing worse than people used to do it under GA, and now they want to change and they got complication, and then you got double jeopardy to the patient. I think yes, they should probably plan it in a month time from now, for example, to change it to like rehearse. But I think this is dangerous. I would ask the people who are doing it under GA to shift TAVI, necessary TAVI, to people who are doing it under conscious sedation.
Excellent. Dr. Khalid, the same question. Did you do TAVI in this period? But also one other question, as we learned from Dr. Mohammed Ataibi and Thomas and Fahad mentioned already that are we moving to the right thing now with COVID, that we should be minimalist and this is the way it should be done for TAVI patient, less personnel in the cath lab, sent to monitor area, not CCU, and early discharge. Is this the right thing, or we are this is only in the COVID, and when it's out, we'll go back to what we used to do?
Yeah, we have done few, but they were not COVID positive, but it's during the COVID pandemic. And we have followed the same suggestions said by my colleagues here. The thing is, before the COVID, we did something evaluation called TAVI pathway with collaboration with Medtronic. And basically what we did, we looked into our practice and we saw what things we can minimize during TAVI, which makes it cost effective and safe. And by following that, we shifted already before the COVID pandemic into the local anesthesia, no anesthetist in the room, no echocardiographer in the room, just local anesthesia with minimal approach. And when the COVID happened, we just continued to do that. It just, you already minimized the personnel, the equipment, the hospital stay, and it is effective actually. And we have we have data on that, it is cost effective and safe.
Excellent. Dr. Fahad, the same question of TAVI during this period. Also for you, just if you don't mind, comment on patients that have coronary artery disease and CVRS and you want to do them now. Shall we change to do both procedures in the same setting to decrease exposure? Or shall we do it a stage as we used to do before?
Okay, so regarding first doing it during the COVID area, I mean, a minimalist approach, we have adopted minimalist approach for a long time, for a good number of years in our center, and with a good results, and it was very cost effective and discharge early, like next day. So this is important. During this pandemic, we haven't done any cases for multiple reasons. One of them, patients are not comfortable coming to hospitals, especially they are kind of, you know, those aortic stenosis, unless they are really sick and they are impatient, then they have no other choice. But patients themselves, they prefer to postpone it. Also, another challenge is we are in Ramadan period. Also, it's another thing, even before this pandemic, people, they wouldn't like to do this procedure during Ramadan time. But I think after Ramadan and already people are calling, they are asking when we will do the procedure. And this is important. So we should have a pathway during COVID area, because this pandemic is not going to go away in a number of weeks. It's here to stay. So we have to work around it and without jeopardizing the safety of the patient. Regarding your question about coexisting coronary artery disease, it depends on two things: the complexity of the coronary artery disease and also the kidney function. So if a straightforward lesion, we will do it at the during the same procedure if it was picked up in the CT scan. Actually, I prefer to do a CT scan to look for coronaries and aortic and femoral tree. But if it's not, then we bring the patient to do an angio, and if it's a straightforward lesion, to be done. If it's too complex of coronary anatomy, then I prefer to stage it. So do the coronaries first, and then do the TAVI in the second stage.
Excellent. Thank you very much. Back to you, Thomas. There is one of the audience asking about the medication after TAVI. Do we change anything, like a dual antiplatelet therapy, anticoagulation? Does anything change, Thomas, or no?
I mean, when we do the TAVI, we have to start the balanced threshold. So, for example, the patients on the warfarin are in this category of patients. If they are stable, we try to postpone them, but because it will extend the length of stay in the hospital. Otherwise, we only do a simple dual antiplatelet therapy for 3 months, and then we stop the clopidogrel and we stay with the aspirin alone. This is, I mean, as you know, there is no consensus on the subject, but we have found, so for example, we don't give clopidogrel as a loading dose anymore. We have found that we have less vascular complications, less bleeding, and we just give them in the morning of the case, like a PCI. We do the case, and if there is no bleeding, the day after we start with the dual antiplatelet therapy, and then we keep it for 3 months, and then only with aspirin. This is the way to do it. If we have a warfarin, we don't give clopidogrel. We just keep aspirin and oral anticoagulants. That's it.
Excellent.
So as I think the question was regarding some of the treatment used in COVID, they can attenuate the effect of Plavix. Maybe that's what the reason the question was raised.
Yeah.
So but I think I agree with Thomas. This is not a stent. I think we still can use the same dose. Exactly. I think that's why that question was asked.
Yeah, but if just to make it clear, we are not avoiding any question or any answer. As I said, except one patient, all the patients that we have been doing were all either COVID negative, and if they were COVID plus, they were, I would say, simple ones. They had minor symptoms. So they were not having any additional medication. That's what I say. So as you know, for example, we have been banning using of any anti-inflammatory medication, the steroids, all these things, because we thought in the beginning that it will multiply the aggressivity and the invasiveness of the COVID plus. So we don't stop any cardiac medication on the other hand. So I mean, I would say we don't have enough experience, none of us in any country of the world, to be able safely and reliably to say we can stop this or we could do this. What if we go back to our discussion, Dr. Khalid, I think with regard that anticoagulant, oral anticoagulation or a dual antiplatelet therapy, it's like before. We didn't change anything. This is what I want to say.
Yeah, I totally agree with you, Thomas. I just want to
that's true.
explain why that question was raised. Yeah.
Okay.
I think it's also what his point that he mentioned that question that COVID-19 patients, they have a more tendency to have a thrombosis. So people are afraid about stent thrombosis would be more with the COVID positive patient. And he said if there is a possibility for valve thrombosis, is there any way to do longer anticoagulation? But I think you handle it very well. Anyone would like to comment on anything before I go back?
Yeah, on this topic, if you allow me. I don't think, and Thomas said it, I don't think we are supposed to do TAVI in a COVID positive with active disease. This is very important, because then it comes to the decision, it's really what is his prognosis. So I'm not supposed to be in that situation. But because if it's COVID positive only without disease, doesn't mean that you will be hypercoagulable state. So I don't think we have enough data to change our anticoagulation regimen.
My question to my colleagues is, if somebody is COVID positive, what's the rush of doing him? I mean, he's having an infection. We don't know how he's going to progress, if he's going to deteriorate or not. So personally, if somebody is a patient with aortic stenosis and he's COVID positive and his condition is not requiring urgent intervention, I would wait until he's free of COVID and then do the procedure rather than he's COVID positive.
But if, let's make this is like I just add to it and make another question. If it's COVID positive, intubated, and the clinical decision or the evaluation think that severe AS playing a big role, is there any way just to do balloon valvuloplasty as a quick relief? Then you can evaluate if he survived after this case. So we'll start. Or Fahad, you want to take that?
I mean, it's hard with the COVID patients because if they are severe and they are intubated and their X-ray is typical of COVID, then he's not going to benefit of doing any intervention. These people, their mortality is very high. So I wouldn't expose even the staff to do somebody who's really highly infectious at this time.
Okay.
So, yeah.
Khalid?
Yeah, I think the choice between whether we go with balloon or valve mainly will be a cost-effective issue. So the question will be, should we go in or not? This is the first question. As Fahad said, those patients, they will not do well. So the answer from the beginning, no. And if somebody is going to go in, I think it's only money matters whether it's balloon or valve. So if you decide to go in, which I don't recommend, I would go with a valve, not balloon valvuloplasty.
Sure. Dr. Mohammed?
It's a difficult situation. Now, I want to stress there is overlap between heart failure and lung shadows when it comes to COVID. And that's why probably now, even if you are planning to do CT scan for a TAVI protocol, you should stress to your radiographers or radiologists to have more time looking at the lung, because if there is like infiltrates, then it's very important. So I think I would seriously entertain these two possibilities. There is a good overlap between heart failure and COVID chest manifestation. I will have to have the whole team discussing it probably more than one time, and then we'll go into the issues, pros and cons. Should we really risk our staff, and where the patient will benefit? If things really goes more towards heart failure, that's the CT scan didn't show a crazy paving like shadow or a consolidation which is consistent with COVID, and the whole thing is pulmonary interstitial edema. I think I would start with balloon, but I won't do ballooning unless I have a chance to access TAVI in case if there is open AR happened. So I think this is a serious entertainment. It really needs a lot of discussion.
Good. Thomas, what's your take on that? You're mute, so can you unmute your mic?
Yes, yes. Sorry. I mean, everything has been said by Khalid, Fahad, and Muhammad. But I mean, let me put it this way. The problem is we have been surrounded here by intubated patients for COVID, and they are really very difficult to maintain stable, even if they are intubated. And sometimes many of them alternate dorsal and ventral position in order to improve the oxygenation or all part of the lung. So, I mean, these patients are difficult, really difficult to move from the ITU beds and push them and bring them to a cath lab, whatever. In some of these patients, we had some patients, but to be honest, not with severe aortic stenosis. Some of them had moderate, and we put ECMO on them, but we put the ECMO not for the heart failure, we put it for the respiratory failure. But in my mind, I mean, as there's no lessons to give because no one, I don't think that many people have been living this. If we keep it very rational, I would say if the patient is sick enough because of the aortic stenosis, and it will be very difficult to make the differential diagnosis, and we can push them to the cath lab. Once he's in the cath lab, it's so difficult to move him. Let's do everything in the same time. I mean, if you puncture the artery, you put the 12 French sheath to do the valvuloplasty, put the 16 French sheath and do the valve, and that's it, you know?
Good. Question for you, Thomas, and you may be the best person to answer because of you're a cardiac surgeon. Shall we say out of this that all severe AS should go for TAVI in this time?
You know, if I was honestly, you know, the debate is almost closed in terms of if TAVI can be done in all patients. The question is yes. The good way, I think, to look, is it wise and long-term effective to do TAVI in all patients? This is a different question. From my point of view, it's very important if the patient have a long time durability so far, to be sure that we give him what we know best, which is the longevity and durability of surgical valves. But here I'm talking about patients who are 60 years and below. I'm not talking about low-risk patients who are 70, 75. To be honest with you, in our practice, all patients, for example, which are 75 and above, are having TAVI without any discussion now, you know? And we are progressing year after year to be sure that, so the only substitute is the durability. So if all patients can have TAVI, yes. Should they all have TAVI? I don't know. We have to think about it. For example, the question of bicuspid will still open. You know, we still don't really know how these valves, because of the severity of the stenosis itself, because the under deployment of the valve itself, how long it will be. And what I can tell you as a surgeon, Fawaz, and this is very important for our colleague cardiologists to understand, is that if you want to do a redo after 10 years in TAVI, I'm not sure it will be as easy as doing a TAVI as a valve in a surgical valve. I can tell you that it is usually now when we have to do this, many patients ends up with having a Bentall procedure with the aortic root, which is completely destroyed. And in that case, you better have a very, very, very good surgeon in your team. So, you know, this is the point. We have to put all these elements together and then choose for the patient. So age is not enough. The expectancy of life, if there is no single coronary artery disease, because the question of catheterizing again the coronary arteries is very important for the future. So, you know, all these things, we have to put them together. It's not as easy as it is to answer, you know. I will not say yes like this.
I think you did answer it in a very good way. Thank you very much. So it's 5 minutes more to finish our webinar. So if you don't mind, everyone give us 1 or 2 minutes or even less than that. Mainly advices for post-COVID-19 era. Where should we stress? If you are a director of the cath lab, what you should do after this, and what's things that you should change in handling TAVI patients. So any one of our panelists, then we'll close with Dr. Moudine. Khaled?
I can say something here is, yes, we learned that we can do minimal approach. We can shorten the hospital stay. I think we should think from now, after the peak of the pandemic, how to resume the TAVI procedures safely. And I think those precautions we are taking, extra precautions we are taking now, I think they are going to stay with us. But I think the practice during COVID-19, I think it will continue with us post-COVID-19.
Good. Dr. Fahad? Can you unmute your mic, Fahad?
Sorry about that. I was talking to myself. So life after COVID is completely different. Life and the procedure will be completely different. I think we should take in consideration the safety of our patients and safety of our staff as well. So we have to have a clear pathway, a clean pathway as well for those patients, adopting the minimalist approach and early discharge post-procedure. Thank you.
Excellent. So Mohammed?
So I will stress on 4 points. Number 1, disease, do severe symptomatic aortic stenosis, particularly if they are in hospital. So you have to do that. 2, check your availability. Resources. Do you still do the procedure? Do you have issue with the resources or no? Can you do it? If yes, go to the procedure, you do it the routine, usual way, minimalistic approach. This is very important. Don't try to invent a way now during the COVID. So if you are not doing it minimalistic, don't do it. Send them to somebody who do it minimalistic. Then the staff, protect your staff. Minimal and complete PPE and N95 and complete shield, and shield your patient who is COVID positive.
Excellent. Dr. Moudine? If you unmute your mic.
I would say all of the above.
Very smart answer.
You know, I think, again, I want to really repeat it again and again, that aortic stenosis kills is a very severe disease, which is very easy now to treat and save in the era of TAVI. This is really have to be kept in the mind of everybody. And I think TAVI would gain more place in this disease than ever, because as we said, it simplifies the pathway, it optimizes the resources, and it offers whatever we want if we use what we call the best practice. And Dr. Mohammed have been saying, I think if you don't have enough practice and you are ethical enough, respect the patient, send them to those who knows, and give yourself a chance to learn much more. This is very important. And I will end up by saying that it takes, in my mind, there is no question that TAVI is becoming the gold standard today, but we have to be really very humble and wait. We know that TAVI still have a lot of blanks to fill, I would say. We need to learn a bit more about the durability and some particular indications like bicuspid, so we have to wait and see. And once we have put all this together in this environment with no problems of communication between the cardiac surgeons and the cardiologists, it's easy to choose the indication. I mean, it's easy for me because I know how to do both. I see no reason why it cannot be easy for any cardiologist or any cardiac surgeon based on the knowledge. It's not because I believe, I just feel it's like this. This is one. And if we have a disease like what we're having here, as Muhammad has been saying, we have to protect our nurses, our people who are working in the cath lab. And if we can do a simple procedure to save the patient's life, I think we should choose it over doing a complex one. This is as easy as it is.
Thank you very much, Dr. Thomas Modine. It was a great presentation. You handled the question very well. Your presence was an excellent and educative. I also would like to extend my thanks to our panelists, Dr. Fahad, Dr. Muhammad, Dr. Khalid. I think it was a very useful webinar. For our audience, thank you very much. We have more than 380 registered with us today. And I wish that we deliver the information that you need with the, how to handle TAVI and COVID-19. I'd like to thank Medtronic for their support for this webinar. They always have a good collaboration with the GIS. For our audience, stay tuned. Tomorrow, part of the GIS activity will do ACC review with a new team at 9 p.m. Kingdom of Saudi Arabia time. Thank you very much. Have a good night.
Thank you very much. My pleasure. See you soon, guys. Bye-bye. God bless you.
Goodbye.